Bismillah ar-Rahman ar-Rahim. I am Professor Bedeir from the Urology and Nephrology Center, and I am going to discuss with you the lecture entitled Urinary Tract Infection. You can find the PDF of this lecture on the site for this online learning. And let's start with the definition of bacteriuria. Bacteriuria is the presence of bacteria in the urine, whatever the number of bacteria may be, because the urine is devoid of bacteria. And this bacteriuria can be divided into symptomatic bacteriuria, which means the presence of bacteria in the urine in association with the clinical manifestations of its presence. And it may be asymptomatic bacteriuria, which means the presence of bacteria in the urine without any clinical manifestations. The question is, do we need to treat asymptomatic bacteriuria? And the answer is sometimes yes. And in this slide you can find the absolute indications to treat asymptomatic bacteriuria, for example, during a pregnancy, and relative indication to treat asymptomatic bacteriuria. And all these indications are controversial. Then we shift to the definition of pyuria. Pyuria is the presence of pus cells in the urine in excess of 5 per high power filled. And this pyuria may be strial pyuria. This means that the pus cells is present in the urine without a discoverable microorganism or culture. And it may be pyuria in association with the presence of bacteriuria, and we call it infection. The main causes of strial pyuria are stone disease, especially Stockholm stone, urinary TB, indwelling catheters and stents, and sometimes this strial pyuria may be secondary to early bladder cancer, especially carcinoma in situ. If we consider some classifications of UTI, we can classify them into specific and non-specific. And of course, non-specific infections within the urinary tract are far commoner than specific infections. And the word specific infection means infection within the urinary tract which is caused by specific microorganisms, and therefore they need a specific treatment. So if we are going to just summarize the word specific, it means specific pathology. And specific pathology induced by specific microorganism, and therefore it needs a specific treatment. We discussed early in the lecture that the presence of any number of bacteria in the urine is considered bacteriuria, but the question is any number of bacteria suitable for induction of clinical manifestations? And the answer is definitely no. But we need a cutoff of number of bacteria in order to induce clinical manifestations. This cutoff of the number of bacteria, which is used currently in the diagnosis of positive bacterial cultures, when the urine is collected by midstream urine sample, then this number is 10 to the power of 4 or 5 colony-forming units per milliliter of the cultured urine. And when the sample is obtained by supercritical puncture under complete aseptic precautions, the presence of even a single colony-forming unit of bacteria per milliliter of the cultured urine is considered clinically significant bacteriuria. Again, clinically significant bacteriuria means the presence of 10 to the power of 4 or 5 colony-forming units of bacteria per milliliter of the cultured urine if the method of collection was the midstream urine sample. On the other hand, even the discovery of a single colony-forming unit of bacteria in a sample obtained by supernomic puncture under complete aseptic precaution, especially in children, is also considered clinically significant bacteriuria. We can call or give the name of urethritis if the infection is arising from the urethra, cystitis, epididymitis, epididymoorchitis, prostatitis, and so on. Another classification of urinary tract infection is complicated and uncomplicated infection. However, this classification is very important because it has a clinical and follow-up consequences on the cases of UTI. By uncomplicated infections, we mean 4 preconditions. These 4 preconditions: the infection should be occasional, for example, once every year, once every 3 years, should be lower, urethritis or cystitis should be in females, not in men or children, and there should be no risk factors or no predisposing factors. If these 4 preconditions are absent, then all other infections are called complicated urinary tract infection. For example, infection in pregnant women, infection in men, infection in children, infection with obstruction, infection associated with catheter, infection associated with obstruction, strictures, etc. Now we shift to after the nomenclature at the beginning of this lecture, we shift to the etiology of urinary tract infection. Etiology of urinary tract infection include 3 items. The first item is the causative microorganism. The second item is the route of infection. And the third item is the predisposing or risk factors. Let's start with the causative microorganism. Of course, bacterial infection is the commonest infection causing the urinary tract infection. And of this bacteria, the E. coli is the commonest. However, other non-bacterial organisms may cause infection within the urinary tract, such as parasitic infection, bilharziasis, protozoal infection, Trichomonas vaginalis, or helminthic infection, for example, Oxyuris. Because bacteria is the commonest organism that can cause infection within the urinary tract, then we have to give some details. E. coli is the commonest organism of the bacteria that cause infection within the urinary tract. However, other bacteria that may cause UTI include Enterococci, Staphylococcus subcutaneous, Klebsiella, and Pseudomonas and Porteus infection. The later Pseudomonas and Porteus infection are rare, but they are more serious microorganisms. Therefore, if we discover these organisms before urological operations, we have to eradicate them completely before assigning this patient to an operation. We finished the causative microorganism as the first cause of the etiology of urinary tract infection. Now we shift to the second item, which is route of infection. And by far, the ascending route of infection is the commonest route of infection. However, other routes of infection may be there, such as blood-borne infection, lymph-borne infection, or others. And all these other routes of infection, apart from the ascending, may be found in emetis, and you have to start investigating this patient as if he had this disease. And this slide demonstrates the stages of a urinary tract infection, beginning with the colonization and going up to uroepithelial penetration and ascension, and then causation of pyelonephritis, and then injury of the kidney or acute kidney injury. When you meet a case of suspected acute pyelonephritis, what are the minimum investigations in a case of suspected acute pyelonephritis? These minimum investigations include: number one, urine analysis and urine culture; number two, the ultrasound, pelvic and abdominal ultrasound; and then number three, CBC, complete blood culture, for estimation of the leukocyte count in order to those who are attending the ICU. Now we shift to the treatment of the acute pyelonephritis measure. You have to tell your patient. So the treatment of acute pyelonephritis include general unsupported measures. You have to tell your patient about these measures, and at the same time you have to tell him the specific measures. Specific measures: if the patient can tolerate oral feeding, if he can take something by mouth, the drug of choice, the empirical drug of choice is fluoroquinolones. If he cannot tolerate oral feeding, then you have to start the third generation cephalosporin for 2 weeks. So the duration of treatment of acute pyelonephritis is 2 weeks. We have rare forms of pyelonephritis, such as emphysematous pyelonephritis, granulomatous pyelonephritis. They are outside the scope of your study level at this time. Chronic pyelonephritis is also not so much important, but you can study this slide at home. Now I discuss with you the perinephric abscess. The perinephric abscess, the clinical manifestations of perinephric abscess are the same as acute pyelonephritis, but in a more severe form. More severe form, very severe line pain, hectic high-grade fever, irritative voiding symptoms, and exquisitely tender line on examination. And the cause of the perinephric abscess may be primary perinephric abscess, which is blood-borne infection, or secondary perinephric abscess, which is secondary to a disease within the urinary tract, such as stone disease or parenchymal abscess or pyelonephritis. The secondary perinephric abscess nowadays is the commonest. It accounts for 85% of the cases. In the past, before the discovery of penicillin, before 1945, the main cause of perinephric abscess was primary abscess. Now I'll shift to treatment of perinephric abscess. And treatment of perinephric abscess is essentially a drainage of this abscess plus the specific antimicrobial or the specific empirical antimicrobial agents, and then general unsupported treatment. If the abscess is composed of one locule or one cyst, then percutaneous tube drain is the solution, BCTD, or if it has multiple cavities or multiple cysts, we can drain it by open drainage. Let's go directly to cystitis, with the commonest infection within the urinary tract, and it occurs mainly in women. And the predisposing factors, etiology, and incidence are the same as discussed before early in this lecture. Let's discuss together the manifestations or the clinical manifestations of cystitis. They include irritative voiding symptoms, which is frequency of micturition, pain during micturition, urgency and urgent incontinence, and in addition, occasional hematuria may be there, especially in honeymoon cystitis or in severe forms of cystitis. The treatment is essentially a 1-week treatment, and the drug of choice, the empirical drug of choice, fluoroquinolones. However, you can start with the trimethoprim sulfamethoxazole or nitrofurantoin as a treatment for 3 or 5 days. And this slide demonstrates the differences between fluoroquinolones, trimethoprim sulfamethoxazole, and nitrofurantoin. You can study this slide at home as well. This may be the last 2 slides in my presentation, which is prostatitis, acute prostatitis and the chronic prostatitis. Acute prostatitis is the acute inflammation of the prostate gland, which occurs usually in diabetic men. In the more than 90% of the cases, it is associated with diabetes, and therefore you have to check your patient for evidence of diabetes, whether by assessing the blood level for glucose or by asking this patient about his history of diabetes or history of diabetes in the family. The clinical manifestations of acute prostatitis are 5 manifestations. These 5 manifestations include acute pain in the perineum and in the prostate region, high-grade fever, the obstructive urinary symptoms with or without irritative widening symptoms, and rectal tenesmus. And on examination, if you allow to do such an examination, then severe tenderness on additional rectal examination, and therefore you have to instruct your patient and you have to communicate with your patient meticulously before you do such an examination. The treatment of acute pyelonephritis is essentially the same as acute prostatitis, essentially the same as acute pyelonephritis if the patient can tolerate oral feeding, fluoroquinolones, a drug of choice, and if he cannot, you start third generation cephalosporin. And the duration of treatment in acute prostatitis is 6 to 8 weeks. Now the last slide in my presentation, which is chronic prostatitis. Chronic prostatitis is just 3 notes about chronic prostatitis. At first, it occurs in young individuals. Number 2, it's diagnosed by exclusion. You have to exclude all other serious infections within the urinary tract before you diagnose chronic prostatitis. Number 3, the main treatment is assurance. When you meet this patient with chronic prostatitis, you have to assure him that there is no serious complications of this chronic prostatitis, especially at the level of the potency and at the level of the fertility. Then what's the treatment of this chronic prostatitis? The treatment is fluoroquinolones, the drug, the maestro of the orchestra in the urinary tract, and the duration of treatment is double the duration of treatment in acute prostatitis. That's to say from 8 to 12 weeks. If you, for the remaining part of the lecture or for more details, you can find the PDF file and you study it at home as self-learning. And have a good day. Thank you very much.